Thank you, Daryl. Thank you so much for inviting me to come down and talk to you all. It's really a pleasure. One, because it's fun to come and speak to men with prostate cancer and family members instead of physicians or other healthcare providers. And two, because I get a chance to debunk one of the most famous myths in medicine in oncology care today, which is what exactly is palliative care and where does it fit in the context of having cancer and living with cancer. So I'm Kavitha Dharmarajan. I'm a radiation oncologist and a palliative care researcher at Mount Sinai Hospital. And I first just want to ask everybody here, you guys, what do you think about when you hear the words palliative care? End of life. What did I hear over here? Pain management, yeah. Marijuana, okay. What else? Saying goodbye. So the more we learn about cancer and cancer as a chronic illness, which is basically living with cancer that's not curable anymore, but it just becomes sort of part of a person's life, can be that way for many years. The more we learn that palliative care is actually a type of medical discipline that has a lot of important roles during the course of a person's life, not just at the end of life. It varies in sort of its, how important it is at any given moment, and it can certainly be more important to have access to palliative care, and I'll talk about exactly sort of the definition of palliative care in a minute, towards the end of life, but it certainly has reasons to be incorporated into a person's journey with cancer from the very beginning, in fact. So what is palliative care? So the official definition of palliative care by the WHO, the World Health Organization, is basically that it is it is a provision of an extra layer of support for a person and their family throughout the course of a serious illness. Now, serious illness can mean cancer, it can mean heart failure, it can mean serious diabetes and the complications that come from that. It can mean serious kidney conditions. It can mean serious rheumatologic conditions, serious neurologic conditions. It does not have to be cancer. And when it's sort of described this way as an extra layer of support, kind of sounds good, right? Like, who wouldn't want that at any point in dealing with an illness? The other part about this sort of WHO definition is that it means, palliative care means the reduction of suffering in patients and their families. So that also sounds pretty good, right? Like, that doesn't sound like it's only contextual and relevant to end of life, but at the beginning of a cancer diagnosis as well, when there's a lot of anxiety, there's a lot of uncertainty, there may be a lot of symptoms that precipitated that diagnosis. There's suffering in that, and not for just you, the person who's having the illness, but also for your spouses, your children, the people who are close to you. They are, experiencing the same kind of or suffering in a different way, but they're experiencing suffering as well. So palliative care is the provision of a type of care that is meant to reduce suffering in patients and their families. Then palliative care is also, as part of this definition, to reduce pain. So notice that before I said that a palliative care is meant to reduce pain, I said palliative care is meant to reduce suffering. So there's two sort of, pain is a type of suffering. It's true, when you're having a lot of pain, it feels really bad and you're suffering. But there are so many other dimensions to suffering. And so palliative care is sort of a very holistic approach to patients and their families in a way that helps to reduce suffering, not just pain and physical symptoms that might be a result of the cancer or as a result of the treatments of the cancer. And that's kind of where I come in, because I'm a radiation oncologist, but I mentioned that I'm a radiation oncologist and a palliative care researcher. So I think as a radiation oncologist, I have a tool in my toolbox. That's my intervention. That's my way of treating cancer. How many people in the room have had radiation as part of their treatment? More than, maybe about, probably more than half. I'm not very good at math, despite the fact that I'm a radiation oncologist. But it looked to me about half, or maybe a little bit more than half. So when I interact with a man with prostate cancer, it's usually because the prostate cancer has metastasized to the bone, or basically has spread outside of the prostate to a bone, and the bone is causing some pain or other types of suffering, or we're worried that it might cause pain or some type of suffering at some point in the near future. And so I deliver radiation treatment to that bone. It's very similar to the radiation treatment that you get to the actual prostate or to the pelvis, but the intent of it is different. Has anyone had radiation treatment to a bone? So that means most people have had radiation treatment to the prostate. So let's go back to what I said just now. The intent of the treatment is different, and that means that the way that the treatment is delivered is also different. And the outcome that we're expecting from the treatment is also different. When I give radiation treatment to a bone, I'm giving palliative radiation. I'm giving a radiation treatment that is meant to treat the pain or prevent the pain, to treat the symptom, to treat some degree of physical symptom of suffering. I also happen to be treating the cancer, but that's not my ultimate goal. My ultimate goal is to get someone feeling better than they were before they came to talk to me. And so I can do that in one session of radiation. I can do that in 5 sessions of radiation. I can do that in 10. When a gentleman gets radiation treatment to treat the prostate cancer, the goal of that treatment is quite different. The goal of that treatment is actually to cure the cancer, to cure the person of the cancer, to eradicate it. That treatment may take months. Has anyone been on radiation treatment for 2.5 months? How was that? Chapter closed, right? Pretty tiring, a drag. A lot of symptoms from it, probably urinary symptoms, sexual function symptoms. May take it a while to recover from that. Sounds like a story that you recognize. So that treatment is pretty intense. You have to go every day to get radiation treatment, so it cuts a lot into your kind of day-to-day life, activities, not just because you're actually having to go to the hospital to get a treatment, but also because of the side effects that it's causing. And it's causing a lot of fatigue, a lot of other symptoms. When I give radiation to the bone, it's a much, much shorter course of treatment. Like I said, it can be even as little as 1 session. Should be no more than 10 sessions. And the side effect profile is also quite different. It can still cause some degree of fatigue. Sometimes it can still cause a temporary period of more pain, which we're learning how to do a better job at treating as radiation oncologists and palliative care physicians. But the ultimate goal is to improve function. Improve your function, improve your symptoms, reduce your symptoms. So there's sort of 4 things that I want you guys to take away from my talk. And I'm going to try to actually not take the whole 11 more minutes that I have, because it's the end of the day and you guys have been fabulous to be here listening to lectures all day. And I hope it maybe leaves a little bit more time for some question and answer, which I think is the most important thing. So the first is to debunk the myth that palliative care does not mean end-of-life care or hospice. That it's a treatment that, or it's a type of care. It's like a philosophy of care that aims to reduce suffering, to reduce pain, and to add an extra layer of support to the lives of patients and families who are dealing with serious illness like cancer. The second thing that I want to make sure that I get across is that it's important to be empowered to ask questions of your providers when you're seeing them. Ask hard questions about what it is that I'm actually going to expect if you're talking to me about this treatment. What am I actually going to experience? When are we going to reevaluate whether this is worth it or not? Especially if we're in a situation where the cancer is not at a curable stage, but it's at a chronic stage. You could, many gentlemen live for years and years with metastatic prostate cancer. So at that point, every decision becomes even more important one, which is that how is this actually going to affect my life, given that I know that it's not going to cure me, and is it worth it? And helping helping the folks that you see in the clinic, the healthcare providers, to know what you're actually thinking. It's really helpful for them because then they can think with you and make decisions with you, not for you, that are going to be best aligned with your preferences and your goals for treatment and for your life. And the third thing that I want to get across is know what's important. So, like I said, at the point when cancer is at a stage where you just got to we're living with it. It's coexisting with us to a certain degree. It's important to know what's important and to be prepared. Be prepared. We hope for the best, and we're prepared for the worst. And in that way, it can sometimes reduce our anxieties about what might happen to our loved ones, to our our life situation, if there comes a point where we can't actually be, or where you can't actually be, involved in it in the same way that you would want to be. So to be able to know what's important, and those core values that you have, those can help to drive some difficult decisions down the road in terms of treatments. When to continue doing treatments like radiation or chemotherapy or surgical treatments, and when to say, nah, I don't know if that one is going to be worth it for me. Let's not do that one right now. We can think about it later. And that's really kind of what I wanted to make sure that I got across. So I'm going to end here, and I think that the next thing that we have is discussion and questions.
Thank you. All right, so if everyone will pick up their microphones, and everyone say hello so we know the microphones are working.
Hello.
Hello, hello.
Hello. Hello. Hello.
Excellent. Okay, so let's start with Dr. Carlson. So, you described almost a definition of active surveillance as something related to Gleason 6, and there are all the charts and everything, all the doctors agree with it, I agree with it. Most clinicians around the world look at a Gleason 6 today and say, that's barely life-threatening. So there's the risk that is defined by evidence and risk defined by doctors. But there's also risk defined by the individual patient, based on their age, their culture, who they are, how their life has progressed, what risks they've done in their lives, their other comorbidities and other diseases and such. their social standing, social situations, married or not, partnered or not, et cetera. And then there's the other set of risk evidence that's sort of predicated on how families and friends define risk for that patient, for the social constellation and the familial constellation that patient inhabits. So how does an epidemiologist like you sort of understand all of the other things that have nothing to do with something that we could chart out on a Likert scale or something?
Wow. It's a brilliant question. I'm not sure how to answer that one.
You can take a few minutes.
Because it's really putting all the data together. You know, like you said, a man's age, his Gleason score, and then the life expectancy that's then affected by comorbidities, and how do those align into decision making, and then the pressure, like we talked about, from your family around you, and then your perception of risk, of your own risk. It's a really tough question, and I think the answer is, it's not what's important to others; it's what's important to you. And then you really have to think about the risk that your cancer will progress within your lifetime, and given your comorbidity status, maybe you have diabetes and hypertension and you're obese, and that poses a greater risk to your life than your low-grade prostate cancer.
Or your high-grade prostate cancer.
That too.
I mean, active surveillance in a general sense, obviously Gleason 6, 2 cores, maybe even 3 cores if you want to stretch it. Certainly like a PSA 10 or under, maybe 11 or 12 if you want to stretch it. Certainly older guys more likely than younger guys. But, a guy with a Gleason 8 or a Gleason 9 or something and an elevated PSA around 20 or 30 may also think of himself as, I'd rather for now do active surveillance if I have a lifetime of cardiac issues, or I have or on and on and on.
That's right. So the way you can, tackle your problem and question statistically or from an epidemiological perspective is to put everything in a mathematical model. And we call those nomograms or risk calculators. And there are a couple of those that exist that are online. So if you go to Memorial Sloan Kettering's website, we have a nomogram to determine male life expectancy, where you can then adjust for comorbidity. So, if you have a heart attack or angina or blood pressure and all of this. And then it really becomes a competing risk problem. What is your 10 and 15-year risk of dying from your prostate cancer, given your Gleason score, your T-stage, your grading, your risk group, versus your risk of dying from something else? And then how do you weigh those risks into your treatment decision making? And that's really a conversation between the patient and the physician together, using all those factors.
Yeah. And as many in the audience know, and certainly throughout the male care system, there are different nomograms. I mean, Cleveland has a good one, presumably, Sloan, Karolinska, in Sweden, other places. But they're all different. Their algorithms are different, and the evidence that they use is generally different. Are there any that you know of, or is there any? Is there one? Not is there any, I guess. But are there any that take into account culture? Are there any that take into account race, like an African-American man's idea of active surveillance being appropriate or not versus a Caucasian man in contemporary United States or East London,
Yeah, it's harder to put those factors into a mathematical model because we don't know how those sort of predict the outcome. So what you need to look at is what we call calibration. So how does the model predict your outcome compared to what you actually observe in the real world? And what's most important is to use a nomogram or calculator that's developed on the population you're in. So, you can't use a Swedish nomogram here in the US, for example. But all those other, intricate factors, I'm not sure if we can put them in a model.
Yeah, and what we're also finding is the nomogram becomes sort of not a corollary, but sort of a sidebar thing to discussion among other men. That the choice around active surveillance seems to be less made within the context of a doctor's consult and more within the context of a consult among other guys in a support group, as we're familiar with. But, a large number, a higher percentage of guys never see a support group in their lives, online or in person. Those guys are making that decision within the context of their families or friends, or in the dark of night when they're searching their heart as to what they want to do about not just cancer, but that they want to be treated. Because it's often less about the what I need to do to live longer, but for many guys around active surveillance, it's about, do I want to be treated? Do I want the challenge of the fear of undergoing anesthesia if necessary, or taking pills for androgen deprivation, whatever it is, versus just ignoring it, which is neither watchful waiting nor active surveillance. It's just another way of getting on with their life. And for some men, that's just valid because it's nothing you could do. You can't force them into an OR, So it's a much, I want to propose the idea, and I think some of the questions received online sort of support this. The choice for active surveillance isn't really as simple as just Gleason 6. And we know Jonathan Epstein, brilliant. We love him in male care. He does all of our second opinions on biopsies. He's great. But it's still not enough around the discussion of active surveillance. And it's a failure of where we are around that. Because it is one of the most vital tools, not only for designing, your course of treatment from that day, from the day of diagnosis forward, but it's also sort of a kick in the butt as to what life means to you. It's a reinvestigation of where somebody 40 years old and older wants to take the next 40, 50 years, hopefully, or not, And it's also a challenge for the immediate, month or two where you make that choice, And, the challenge for the three of you and all of our other speakers and every doctor on the planet is to help men get to the point where they own that choice without beating themselves over the head later on that they made the wrong choice. That whatever choice you make in the moment, it's the best you could possibly have done. So are there differences? I was going to ask another question that came in. Are there different considerations for active surveillance for black men? Are there?
It depends on who you talk to. Our approach at Memorial Sloan Kettering is that that all men are eligible for active surveillance depending on their risk group to begin with. But of course, there's individual considerations, age and family history and race and genetic status and so on and so forth. So it's always an individualized decision, in consultation with your provider. But in our case, race is not something that we use as an exclusion criterion for active surveillance.
Okay, good. So for Dr. Hamilton, we had easily 60 or 70 questions that relate, that's actually low relative for a topic, but they were precise around what are these tests relative to my body. So I'll just ask a couple. If you can't answer that, or, that's cool. But so one, they wrote don't, but I guess the correct word would be doesn't. Doesn't, or maybe don't. Don't environmental and epigenetic factors and our unique immune systems trump genetics?